Here we go.
Hey everyone, my name is Kate and I am an educator for NICOM. And we're just going to go over quickly how to use it and why NICOM is important for every patient. So the goal for any patient, whether it's you, me, the people who come to ICU, is perfusion. Because we want to make sure we're getting adequate nutrients to the organs and thus sustaining life. Now, most commonly we measure perfusion by blood pressure, cap refill, making sure our patients peak warm and dry, urine output, lactate, but those are all late signs of perfusion. What we need to focus on more is hemodynamics. The reason because of that, if you look up the equation for blood pressure is the change of pressure times compliance, or my patient's vascular tone, is going to give you the amount of flow going through the vessel. But that is assuming that compliance, or your patient's vascular tone, is constant or unchanging. This doesn't work because how often is our patient's vascular tone changing? All the time. Therefore, we cannot say pressure equals perfusion. I can have a patient with a good blood pressure while everything else is going down the toilet because I'm just trying to overcompensate to maintain. By the time my pressure is low, the damage is already done. We're going to find those numbers on here showing inadequate perfusion before blood pressure. So we're going to talk real quickly about the three components to flow or hemodynamics: preload, afterload, contractility. The first form of flow we're going to look at is preload, because that's what we'd like to go to. We think of volume when our patient's sick. Let's get them fluid and see how they do. So here we have stroke volume and stroke volume index. Ignore SVV. That doesn't matter, that's irrelevant. We're going to focus on stroke volume index because anything that's indexed is pertinent to my patient's body surface area. Now there's three ways to find out if our patient is preload responsive, meaning will fluid help with perfusion, because that is our goal. We're not trying to maintain a blood pressure, we're trying to maintain perfusion. Once the passive leg raise, which we didn't create, we just have a way to standardize it where we lift the patient up for 3 minutes, head to bed 30 to 45 degrees, legs of the bed flat, SCDs turned off. Don't titrate any pressors, any sedation, any vent settings. If you have any extra fluids like NS at 250 or something like that, turn to TKO. Lay the patient up for 3 minutes, get an average SVI baseline. Then lay them flat, lift up the legs, put the pillow underneath the legs. Don't let the patient lift his or her legs up themselves. We want to do it for them and put the pillow under. You'll need another nurse or a CNA to help, because if the patient lifts up their legs, they could be changing their vascular tone by vagling. If your stroke volume index increases by 10%, which it will calculate for you, you now know your patient's preload responsive. Preload will help with perfusion. It doesn't mean you have to give volume, but now you know that preload volume will help with perfusion if need be. If they are less than 10%, we now know they're not the yellow numbers, it's not preload. So let's look at contractility. What's my cardiac index? If my cardiac index is not where I want it to be, on a healthy person, ideally they want 2.5 or higher. Someone with a cardiac history, sometimes they want 2.0 or higher. It's whatever you and your physician decide. But if that number is low, consider your inotropes. That's when you're going to probably look at dobutamine or Primacor. If it's not that, so it's not the blue, we're now going to look at the purple numbers, which is my patient's vascular tone. TPR, TPRI, total peripheral resistance, total peripheral resistance index. A good vascular tone is like sipping fluid through a straw. That straw is my tone. As I sip that fluid, I don't have to sip hard, I get as much fluid as I want. Correlate that to the heart doesn't have to work hard to perfuse. But if we are too constricted, imagine sipping that same amount of fluid through a coffee straw. The heart has to work harder and we're not going to perfuse as well. How do you know when your patient is overconstricted? Once you see pulses, black toes, poor urine output, right? The damage is already done. We will see it by typing the map and having it show up on here. So for patients on pressors, you can enter the map and do that as you're going up on your pressors, titrating up or down to make sure we're not overconstricted. We have a lot of patients that present overload when they're actually intravascularly dry, and vice versa. This is just an extra piece to the puzzle for us to make sure we're choosing the right lever of flow to manipulate to make sure we're perfusing the best that our patient can. There are studies that are showing decreased length of stay, decreased ventilator days, decreased mortality by using dynamic assessments, because dynamic assessments is better over static, like blood pressure. Thank you.
And we can monitor patients without doing the passive leg raise and the bolus test. So if like I have an ICU admit that's on pressors, what are we looking at here to change our pressors?
So for pressors, we're going to look at TPR and TPRI. So as you go up in your pressor, we should see TPRI increase, which is what we want. But if we're getting outside of the reference range, which the cards are back here to show you, maybe consider changing up what you're doing right now. Maybe it's time to check and see if your patient's fluid responsive again. It's okay to be a little out of reference range. Also, you don't have to do a passive leg raise or fluid bolus to assess if your patient's preload responsive. You can just watch your trends. As you give fluid, if stroke volume index goes up, this number right here, great, your patient is preload responsive. If you're giving fluid, it's going down, your patient is not fluid responsive. Consider maybe slowing down your bolus, or fluid's not the answer. You can talk to your doctor to see what other method you want to go with.
Thank you.